Okay, good evening. Welcome to the MyCP webinar series. I'm your host. My name is Paul Gross, and I'm here to basically give you an introduction to CPRN and then turn it over to Dr. Bollo, who's a pediatric neurosurgeon at the University of Utah and Primary Children's Hospital in Salt Lake City. So tonight's topic is intrathecal baclofen pumps. And these webinar series are really intended to give the community a chance to hear about the research that we do and give them a chance to interact with the researchers directly. So our agenda tonight is, as I said, quick overview of CPRN, or the CP Research Network, and then an overview of, and I'm going to start to use the abbreviation for intrathecal baclofen pumps, since that's a mouthful, ITB pumps in the treatment of cerebral palsy, and then we'll go into an open Q&A. So last year at this time, we announced that we had merged CPRN, or the Cerebral Palsy Research Network, with another patient advocacy organization called CP Now that was founded by Michelle Schusterman. And I'm trying to shift to not telling that whole story and just telling a little bit of the story now that we're a year into that merger. We've really been working close together for the last 7 years and as one entity for the last year. So the Cerebral Palsy Research Network was born out of an NIH workshop that was held in November of 2014. And at the end of that meeting, the organizers stood up and they basically assigned a key area to move research for CP forward to groups of people in the audience. And I was in the audience and had been one of the organizers and was assigned the task of looking into starting a national CP registry, because I had done some similar work in hydrocephalus. The other assignments were the pursuit of comparative effectiveness research, so looking at 2 interventions for a given population and seeing which works better, increasing the study of adults, a long neglected population within cerebral palsy, and then to make sure the field was growing, to bring more young clinician scientists or researchers into the field. And then the 5th area was to advance basic science and translational science, translational being taking things that you learn in the laboratory and making them apply to people in the real world. So we were really founded initially to do number 1. We had a task force working together, and then we decided to form a network to do initially the first 4. And then eventually we got funded for some genetics research, and we really are doing all 5 at this stage. Michelle Schusterman was a parent that was at that meeting in 2014, and her takeaway was that there was a tremendous need for information for parents that had a diagnosis for their kid of cerebral palsy. And so she formed a not-for-profit called CP Now in 2015 that was focused on really providing evidence-based information, but that was consumable by members of the community after they received a CP diagnosis. She's also very focused. She has a 14-year-old daughter with cerebral palsy. She's very focused on well-being for people with CP, and not only the people with CP, but their families that take care of them, and the stress that can create, and how do you really look after yourself too, so that you can be there to take care of a child that has special needs in terms of medical care, and then to fund important research. So we merged our 2 organizations and our 4 websites in the beginning of January 2021. We launched our combined website in May of 2021, and we go under the name the Cerebral Palsy Research Network, or the CP Research Network for short. So our mission: optimizing the lifelong health and wellness of people with cerebral palsy and their families through high-quality research, education, and community programs. So you can really see that it's really embodied the whole of what the 2 organizations did. So some key milestones. We launched the CP Toolkit in 2015, which was this 83-page booklet that Michelle and other people developed and was reviewed by many clinicians to really sort of bring forward the information that parents that got a diagnosis of cerebral palsy for their child would need. And that's been distributed to over 4,000 people since it was created in late 2015. We followed on with a well-being guide for parents and caregivers, and then also translations for the CP Toolkit into Spanish and Portuguese. And then in 2020, we launched MyCP, which allows people to do many things, but one of the key things it allows you to do is get personalized information about CP based on your specific type of CP. On the research front, we launched our clinical registry. That was that first goal that came out of that NIH meeting in 2016, and it currently has more than 5,000 patients in it and is growing every year. We also, both being parents, Michelle and I, of children with CP, we really wanted the research to be patient-centered. So we went and got a grant from the Patient-Centered Outcomes Research Institute, and we ran a process over the course of a year called Research CP, and we set a patient-centered research agenda that was published. You can find a link to it on our website, and it's what drives our research agenda. We've achieved some significant public funding milestones for both the registry and for our genetics research in 2019. And then in 2020, we launched 4 quality improvement initiatives. And Dr. Bollo is going to talk about one of those and a little bit about what quality improvement is. But you can think of it as research and quality improvement are both ways to achieve outcomes, to improve outcomes that just take a different sort of scientific approach to doing it. And then we've had 4 publications, over 20 academic presentations at conferences trying to influence the field. And we have about 8 manuscripts under development. Another one was just accepted recently, and I think we'll have several accepts in the next month or so. So we'll start to publish more of the results of our work. And then lastly, wellness. We launched a virtual wellness program in June of 2021. And we partnered with the National Center for Health, Physical Activity, and Disability to introduce people to the Mentor program, or mindfulness, exercise, and nutrition program for people with disabilities. So the CP Research Network is now a 501c3, and we basically focus on collaborating with institutions, clinicians, physical and occupational therapists, researchers, and the community to conduct research that will improve outcomes. Physically, we have a data coordinating center, i.e. one of our big pieces of infrastructure is our registry, which is just a database of people that have CP and characteristics of them. And that's housed at the University of Utah. We actually have 2 registries. One is a clinical registry, i.e. it gathers data from when you go and visit a hospital. And we have a community registry that allows people to share their lived experience through surveys that we provide. And then we have these education and well-being programs. So MyCP is a cornerstone of that education and engagement. And it is basically a free personalized web portal that sits inside of the CP Research Network for the extended community. It has clinicians and researchers, but it's got over 1,100 people from the community that are engaged in it. And what it allows is for you to participate in research that's in the community registry through surveys. So you can do them on your phone or on your computer, to contribute to discussions about research and about your lived experience, to provide these personalized resources, both videos, books, and web pages related to you to sort of help you sort through our sort of rich website of content. And it also provides access to free fitness programs, which we're currently offering for teens, teens on up. Anybody can sign up. I would encourage you, if you haven't, to sign up at mycp.org. It is free, and we'd love for you to take our the studies that are offered to you there. So just to give you a little more information about these registries, a key piece of information if you have cerebral palsy or if you're parenting a child that has cerebral palsy is what's called the Gross Motor Function Classification Scale, or GMFCS. And that tells you about your child's or your mobility level. And it's kind of a range of a description about your capabilities. You know, can you walk up steps independently, or do you need to use hold a handrail? Can you walk independently in the community, or do you use a walker? Do you use a wheelchair? If you use a wheelchair, do you need support for your head? And so this bar graph here shows you in the registry today, this is when we had a little bit under 5,000 patients, what GMFCS level of 1 through 5 the people that are coming into CPRN sites are measured as. And GMFCS can change a little bit over life, but generally by the time you're 6 years old, that is your GMFCS, and it stays quite stable, although there can be some functional decline. So that's the representation in the clinical registry. And this is the representation of people that are in the community registry. So this is much more of a cross section of people that we've been able to reach online and have participated in our community registry. So you see there's a difference, and that provides great opportunity for us to get different kinds of information from people to accelerate research. So that sort of summarizes our programs in a nutshell. We're very focused on community engagement. This is a picture over here on the right of our clinicians. The last time we were able to gather in person in 2019 at the University of Michigan. It's a subset of the people that conduct the research. We have these educational materials and educational programs with our website and MyCP, and then we're building these health and well-being programs to allow the community to get the benefit of physical activity that's been adapted for people with CP. So the network is spread across North America. The green pins represent sites that are currently collecting data in the registry. The yellow pins are sites that are working on the technology aspects of that. The red pin is a site that is still working through the compliance, kind of more legalese. And then the blue pins are sites that have raised their hand and said, we want to be part of the network in the future, and they're just evaluating that or working through getting to an approval on that. So we exist to accelerate research and improve care for people with CP. And so this is our pipeline. And if you looked at this, 6 years ago, it was empty with a registry somewhere here over to the left and moving on to approval. But now it's quite full. And so on the left is the funnel where we try to generate ideas or find people that have ideas that really need the benefit of multiple centers to really get a high quality answer to their research. They go through a concept review with our investigator committee, then they go on to develop a protocol or a grant. And then if they get funded, they get implemented. Some things are funded internally, some go for external funding. After they execute, some execute for a long time, some execute for a fixed duration. We try to publish, and you see some of the backlog of publishing that we're doing, and then our 4 publications that we have to date. And then we try to take the evidence of what we generate. Oh, sorry, skipped ahead to Rob a little bit fast. And then we try to put it to the back into the clinical practice that we do. The orange ovals represent the quality improvement work that we do, whereas the blue ones are research projects. And tonight, this one that's surrounded by green is our ITB pump QI project. And Dr. Bollo is going to talk about that. So without further ado, I look forward to turning the reins over to Dr. Rob Bollo, who's an associate professor of neurosurgery at the University of Utah School of Medicine. He is a pediatric neurosurgeon and practices at Primary Children's Hospital. And he is the leader of our ITB Pump Quality Improvement Initiative. So with that, I'll turn it over to you, Dr. Bollo.
Thank you so much, Paul. I really appreciated that overview and introduction. And I'm really encouraged by the audience and everybody involved today. And in an attempt to speak broadly to everybody, maybe some of this information will be sort of common knowledge to some of you, but I hope that it's informative, and I think it will be. And I'm happy to take questions at the end. So as I was just saying before, I'm happy to take any clinical questions at the end. My practice is focused on what we would call functional neurosurgery in children. So functional disorders, including epilepsy and spasticity and other movement disorders. So this is an important part of it. And the CP work and the QI work on Baclofen pumps, I think, has been a great collaboration with a lot of centers. So I'm really excited to talk about it today, and let's get going. So again, some of this many of you know, but cerebral palsy is a disorder that impacts movement, balance, and posture. And it's the most common mobility disorder in children. It typically is caused by either injury to the developing brain at a very young age or abnormal brain development. And it's thought to impact between 1 in 250 and 1 in 500 children, so it's quite common. And if you think about cerebral palsy as being a disorder impacting movement, balance, and posture, well, the most common movement disorder in cerebral palsy is spasticity. And about 75, the range is 70, 80%, but about 75% of people, all people with cerebral palsy, have spasticity to some degree. They may have other movement disorders, and spasticity may not be the most prominent one, but it typically is. And so if we define spasticity, the clinical definition is this velocity-dependent resistance to passive muscle stretch. So when you try to stretch it like an elbow or an arm, there's resistance, and it's this muscle tightness. I'll show you a little later a sketch that I used and showed to patients. That's I'm not a very good artist, but that where I try to sort of put this into context. But I think the thing to know about spasticity is it's isokinetic. So what that means is I think the good comparison is dystonia, which is a hyperkinetic disorder, which can be seen with genetic mutations or what we would call secondary generalized dystonia or focal dystonia in CP. And that's when you have a posture and a movement and it's hyperkinetic. There's a lot of movement, whereas spasticity is isokinetic. And so spasticity certainly impacts movement and mobility quite a bit, but it also leads to pain. It leads to a decreased range of motion, can lead to contractures, and it can lead to orthopedic deformities. And I think an important take-home point clinically is that spasticity is typically asymmetric and it's highly variable. So I'll show you this sketch I referred to a little bit later, but essentially there's a motor neuron, a nerve, coming from the spinal cord that goes to the muscle, a muscle. And that's true for every muscle in your body, every skeletal muscle. So not including like the muscles in your esophagus and GI system and things like that. Those have a little bit different setup. But when we're talking about the skeletal muscles that control mobility, the nerve comes from the spinal cord. And then there's a sensor on the inside of every muscle that sort of sends a sensory nerve back to that same neuron in the spinal cord, telling that how tight it is. And that's a positive reflex loop. So without any sort of upper level control, which typically comes from the brain, you have a motor neuron going to cause the muscle to contract and a sensor on the inside of the muscle feeding back to that same nerve saying contract more. And it's this feedback loop that creates spasticity. And what the brain does is modulates that reflex with inhibition. So it dampens it to allow us to not be too floppy or too tight and to allow our muscles to have fluid functional control. So the brain is the modulator. And so injury to the brain or problems with brain development early in life affect that modulation of that reflex. And so it's typically asymmetric. It may affect the right more than the left. It may affect the arms and legs differently. It could affect the ankle and the hip differently. And because of that, no two patients are the same. And because of that, it's highly variable in terms of how it impacts mobility in people. So that's just a picture of a Baclofen pump, which we'll talk about a little bit more there on the right side of the screen. So when we talk about how we treat spasticity, I think about it as this escalating sort of group of therapies. And we'll talk a little bit more about the gross motor functional classification system, which is a mouthful, but the GMFCS that Paul talked about. And we'll go through that a little bit. But think about the left side of this as sort of patients with more mild disease or how we might treat mild manifestations in any given patient in any given muscle group. And the right side, how we are more aggressive therapies. And then So we typically start with stretching and casting. Even stretching and casting and holding things in position can impact the central nervous system and feedback. And then there's physical therapy and bracing to maintain range of motion and maintain posture. There's medications, which I'll discuss in a second. And then injections, the technical term for that is chemodenervation, but it's something like Botox or phenol injections that are given specifically where the nerve meets the muscle to decrease the tightness there. And then there's orthopedic surgery, right? So the problem with spasticity or increased tone is its impact on the end organ or a problem, right? It can cause the hip to dislocate and cause the foot to be in an abnormal posture. And so in addition to the tightness, it keeps things in an abnormal position, and that asymmetric tightness of the muscles like causes joints and orthopedic parts of your body, the bones and ligaments, to be out of balance. And that creates deformity and contracture and loss of range of motion and pain. And that in and of itself inhibits mobility. So we can address those things directly. One of the issues with that, although it's highly effective and an important component of therapy, is that sometimes you don't get a durable response if you don't address the driver, which is the tone, the tightness, the spasticity. So you really oftentimes need to address that, and you get diminishing returns by only trying to fix the end organ while there's still that high asymmetric tone driving the problem. And injections wear off and tend to have diminishing returns. And medications that are delivered systemically that you take by mouth or through a G-tube can have a lot of systemic side effects. And the central nervous system is protected by the blood-brain barrier and very selective about what gets inside of it. So you have to give high doses of those medications relative to what actually gets to its target within the central nervous system, within the brain and spine. And that can lead to a lot of side effects that are unwarranted and can be limiting in terms of how effective those medications can be. So it's this escalating sort of group of therapies, which tends to end in neurosurgical procedures, but for any given patient involves all of them in different measure and in different parts of their body. So I'm just going to kind of go through this. I really like this, and I think this is a very helpful thing for me when I think about patients with cerebral palsy and mobility. And I think one really take home point for me is when I evaluate children with cerebral palsy and I evaluate them for neurosurgical procedures, I think the most important thing is while we are treating spasticity and in some cases dystonia, while we're treating orthopedic deformities and other things, we are trying to optimize mobility. And so whatever we do, we need to keep that in mind. So whatever impact we have on tone or on posture or balance needs to improve mobility to whatever extent is possible. And so when I think about the gross motor functional classification system, or GMFCS, this is for generally like characterizes these pictures and descriptions characterize typically children between about 6 and 12 years old. And I would call class 1 and class 2 mild. That's just a subjective term that I'm using today. That's not sort of scientific, but level 1, those children, they walk indoors and outdoors. Outdoors you can think of as having uneven surfaces. They climb stairs without limits. They can perform skills like running and jumping, but maybe they're not quite as fast, and balance and coordination are impaired. So a mild. And this is a really holistic classification system describing mobility for the entire child. We'll break it down into the hip and the ankle and the leg and the upper extremities and posture and balance, but this describes overall mobility. And again, those are the things we're trying to optimize. Level 2, so a little bit more severe, they need to, as Paul was describing, they can climb stairs and walk indoors and outdoors, but they might need to hold on to a railing. They might have difficulty on uneven surfaces like gravel or outside, and on an incline or in a crowded or confined space. So still walk, we would say ambulatory, but they need a little bit more support. As we go on to class 3, I would call this moderate, and I would Oh, I'm sorry, I'm just going to jump back. So when I think about class 1 and 2, I think the most important treatments, like again, all of those treatments may be appropriate in different circumstances for patients with any GMFCS level, but I think physical therapy, range of motion, stretching, balance, strength, bracing, those are all really kind of the most prominent ones for kids who are GMFCS level 1 and 2. Injections and surgery may play a role in certain areas that are limiting, in certain areas that might be the most affected, but those aren't the primary treatment strategies generally. And then level 3, so they can walk indoors or outdoors on a level surface with an assisted mobility device. They can climb stairs holding onto a railing, possibly. They may propel a wheelchair or need to use a wheelchair over long distances outdoors or uneven terrain. And when we talk with families, we ask, how do you get around the house? How do you get around school? How do you get around longer distances in the community or outside at school? And I think you get a lot of insight from describing those different contexts. Children with GMFCS3 or people, I think medication becomes much more important. And those medications, sorry to use the brand names, but although Baclofen is not, Valium, Dantrium or Dantrolene, Xanaflex, those are much more prominent in the treatment of these children. Injections like Botox and phenol injections to address focal areas of more severe spasticity to optimize mobility. And then these kids are candidates for surgery, and many of them have surgery, very often orthopedic surgery, and they can have Baclofen pumps and even undergo what we call a rhizotomy, which I'll describe a little bit later for those who don't know. I think that these are the most challenging patients to treat. And I'll show a slide a little bit later, but the reason for that is because I think there's an interplay between tone and strength. And I think that affects mobility, and I think you have to really be careful about it. So a lot of children or people with tight muscles, and especially in their legs, they may use the tone in the absence of underlying strength. They may use that tightness functionally. They may have functional spasticity that helps improve their mobility. So children who are GMFCS level 3, if taking away a lot of that tone may impair their mobility paradoxically, right? So you have to really treat the mobility rather than the tone, especially with these children, because they may rely on the tone where they don't have the underlying strength for their mobility. And I think that's an important point as we evaluate these kids. I'm going to keep saying children and kids. I think this all applies across the population, but that's just sort of what I'm used to treating. So I don't mean to be selective. I would call GMFCS 4 and 5 severe spasticity. So they may walk at level 4 short distances with a walker or a reverse gait trainer, but they rely more on wheeled mobility, even at home. And then level 5, as Paul was alluding to earlier, that's the most severe level of impairment. So they may not be able to support their head or maintain anti-gravity head or trunk posture, and all areas of mobility are limited and they are not independent and require transport. In these patients, physical therapy and medications and injections are still critical tools, but surgery plays a very prominent role, and that includes orthopedic surgery, selective dorsal rhizotomy, which I mentioned, and I'll talk about a little bit more later, and then intrathecal baclofen pumps. And the idea with intrathecal baclofen pumps, as many of you know, and I saw that many of you have a pump, is to deliver that medication directly into the spinal fluid. So you're not dose limited by side effects, and it gets exactly where it needs to go. And I just want to talk a little bit about this. I think this picture is helpful. Like, we can talk about it affecting one side of the body more than the other, hemiplegic so-called. These aren't great scientific terms, but diplegic, the legs more than the arms, quadriplegic, all 4. But I think you can appreciate in these 3 photographs, these kids are using their tone for their mobility. And the goal is to optimize the mobility. And so we have to be careful treating spasticity and not having too much tunnel vision. This is that diagram I was referring to, so I apologize for my poor artwork. But if you think about the muscle, which is purple down below, you have the outside of the muscle, which contracts to create tone or tightness. And then that purple is that sensor on the inside of the muscle. And the blue is my poor description of the brain and spinal cord. But the nerve coming from the spinal cord goes to the outside of the muscle, and the nerve from the inside of the muscle, the sensor goes back to that same nerve in the spinal cord. And it's just a reflex loop that's saying, contract, get tighter, contract, get tighter. And the brain sends neurons down that modulate that. So the red line is meant to depict injury, right? And it's typically asymmetric. So an example may be extreme prematurity, where there's been a hemorrhage in the ventricle. So as the brain blood supply was developing, exposure or extremely premature birth led to exposure to high levels of oxygen before the blood vessels of the brain were ready, and they bled. And that can cause a number of downstream effects, one of which, though, can impair the nerve fibers, the white matter around the ventricles, around the fluid chambers where the bleed may occur, and that can create mobility problems or CP. And it might be more on the right and the left, and it might involve stroke. And so it's always asymmetric. And so the idea of the baclofen pump there is green, is to give the baclofen, which basically is an inhibitory drug, directly to that spinal cord area, sort of to replace that motor neuron, the brain neuron that's missing. And the rhizotomy is a selective dorsal rhizotomy is another technique. And basically what we do there is we expose the nerves coming off the bottom of the spinal cord, and that circle there, that purple circle, is meant to be just sort of a blow up, where we separate them out under the microscope into multiple different nerves, stimulate them, and cut the most abnormal sensory nerves to interrupt that feedback loop. And many candidates are more appropriate for one or the other, and I'm happy to get into that if there are questions about that. But I think an important concept is they each have their pros and cons. So there are a group of patients who are appropriate for either. So one example might be that GMFCS3 child who's using their tone functionally, but they have not a lot of strength. So a rhizotomy might take all of that tone away and impair their mobility, and we don't want to do that. But a baclofen pump might be able to do that more gradually by slowly going up on the dose. So a baclofen pump is implanted, is just a pump implanted in the abdominal wall, and the catheter or tube is tunneled to deliver the medication to the spine around, under the skin, around the flank, and we make an incision in the spine, and then under x-ray we thread it up into the spinal canal to the level we think is appropriate to treat that child. And so we then deliver the medicine directly to the spinal fluid, and that's reversible. It's titratable, so we can turn it up or turn it down. We can do flex dosing, so you can get more at night or during the day. And we can gradually increase it as kids grow and have more needs, and they can start to slowly transition to strength and away from tone, if that's important. It can treat both the arms and the legs, which is, so if we put the catheter, if we thread the tip of the catheter under x-ray to the neck, to the higher up, we can also impact the arms. And then we can treat dystonia with intrathecal baclofen. There's a number of different treatments for dystonia. It typically requires much higher doses of medication, and it typically has a lower efficacy. So it doesn't work in as many people. So it usually works in only about 50% of people. And when we're evaluating patients for these therapies, we do a trial. So we do a spinal tap and inject a bolus of baclofen, like a slug of medicine, right into the spinal fluid, and then it sort of peaks in terms of its effect and then slowly gets better. That's not the perfect representation of what life is like with a pump, because a pump is a very slow infusion of medication and not one big slug of medicine, but it kind of gives you a sense of what can be achieved, and it can also unmask weakness. So it can show us, well, if we're worried about a child's underlying weakness, what if we take the tone away with a trial? What are we left with strength-wise, and how does that impact their mobility? So it can be helpful in a number of ways. Some of the cons of intrathecal baclofen are that it's not selective, right? So I can't deliver a different dose of medicine to the right hip and the left ankle. It's all the same dose of medicine, so there might be limitations there. It requires a lot of maintenance. The medicine has to be refilled. The reservoir, there are two sizes. One holds 20 milliliters of fluid and one holds 40. But and the longest you can go between medicine refills, which requires a needle to inject it through the skin into the pump, is about 6 months. Most people refill it more often than that. And then malfunction, so it can break. It's a mechanical system and a device and prone to failure, and that can lead to withdrawal, which can be life-threatening. It's rarely life-threatening, but it's certainly possible. And so most people with a baclofen pump have to know if they travel where they're going to get treatment if there's a problem. They have to have medications to take by mouth or through a G-tube available at all times in case there's an issue with the pump, in order to get them to the point where the pump can be evaluated. And then infection. So that's our main part of our QI initiative, our quality improvement initiative. Baclofen pumps have one of the highest rates of infection in medicine. And I think that there's a number of different reasons for that, but they're not well known or understood. And how we can reduce that infection rate is what our quality improvement initiative is all about. So in the literature, in children, it's somewhere between 5 and 10%. And most studies, if you average them out, suggest it's about 10%. Because the pump doesn't have a blood supply, if it gets infected, it has to come out. That's best practice. Sometimes people try to save it. We're trying to evaluate those concepts through our study, but in general, it has to come out. That can lead to withdrawal if you're on a high dose of medication delivered through the pump. It means going back to the operating room, and it means antibiotics. It can be very expensive. It can lead to an infection where the pump was in the abdominal wall, which can be treated with antibiotics, or can lead to meningitis and a spinal fluid infection, which could injure the brain and spine more. So this is a big problem. And again, of all the devices that we implant, for different reasons, they all have a little bit higher infection rate than surgery without devices, but in children, baclofen pumps have the highest in medicine. And so we really want to try to bring that down and reduce those complications and help improve patients' sort of life and lived experience by trying to really decrease that. And just to sort of compare that to rhizotomy, selective dorsal rhizotomy is a little different in that it's selective, right? I can be more aggressive in your right hip if that's where you need us to be, and less aggressive in your left ankle, more gentle there because there's less of an issue there. It's durable. It doesn't require a device that requires maintenance, and it has therefore a low infection rate, no real mechanical breaking or complication rate, but it's only really effective in the legs. It won't impact the arms. You can't dial the treatment up and down over time. It's all at once. And it causes scarring, and it becomes very difficult to redo, and it's irreversible in a bigger surgery. So as we think about patients who need these types of treatments, I think it's important to understand the pros and cons of each. So the pump we talked about, it has two sizes. It's implanted in the abdominal wall, and the catheter or tube is tunneled around the skin, under the skin, around the flank, and then into the spine, and delivers a continuous infusion of medicine. It's a fraction of the dose you would need to take by mouth or through a G-tube, and there's little to no systemic side effects. So it can get you off of those medicines with a lot better effect. And again, we kind of talked about the complications, but withdrawal, infection, meningitis. And then we think one of the reasons, and we haven't proved this yet, and it's not in the literature, but we hope through the CPRN, through our quality improvement initiative, we can demonstrate this. A lot of kids, with high muscle tone, they can have be very thin and have their nutritional status may be compromised because they're just burning through calories because their tone is so high, and it can be very challenging to get a good nutritional status, and that can impact infection. But it's an infection that occurs at the time of surgery, so there's surgery specific reasons, and those are the reasons we're focused on in our quality improvement initiative. We're tracking the patient specific criteria, which we think are important, but we're focused on what can we do in the operating room to reduce this risk as much as possible, because that's where the infections happen. So the science of quality improvement is different than what you think about clinical research in general, right? We have a known treatment that's good, but it has some potential side effects, or can be some bad outcomes. So how do we improve quality and reduce those bad outcomes? And that's really the science of healthcare delivery and quality improvement. And Paul mentioned the Hydrocephalus Clinical Research Network. So another common device we put in children in neurosurgery is a shunt, and a lot of patients with CP have a shunt as well. And what that is a device that drains the fluid, the spinal fluid. We call it spinal fluid. It's really cerebrospinal fluid, or CSF. It's made in the brain, and we drain it into the abdomen. And you make about 4 times as much of that fluid every day as the system is designed to hold. And so you can think about it like a bathtub with the faucet on and the drain open, and the water level doesn't change, but it's always being replaced. And what an injury or abnormal development of the brain can cause is sort of scarring down of that drain, but the faucet's still running. So the fluid builds up, and there's a lot of reasons for hydrocephalus, but those are some common ones. And the fluid building up can put pressure on the brain, and that can cause a lot of problems. So a shunt is a device that drains that fluid into the belly. And the lining of the abdomen makes and absorbs fluid too. And so it's a large body cavity around the intestines, and we can drain that fluid there or shunt it away, and the body will take it from there. But like Baclofen pumps, that's a device, and there's a problem with infection. So my partner, Dr. Kessel, who together with Paul established and run the Hydrocephalus Clinical Research Network, one of their initial core projects was trying to decrease shunt infection rates. And they developed a surgical protocol. And so you can see at the bottom, the infection rate before initiating the protocol was almost 9%. And then after was about less than 6%. So a significant reduction. And the red bar, if you can see my mouse here on the left, is the mean. It goes up and down as you count the months off and do procedures. Each one of these is a shunt procedure. And then over time, that risk of infection goes down. I'm sorry, each one of these is a sort of a epoch or a time period in which the infection rate was certain. So at some point it was 11 or even 13, and then at some point it was 3, but the average here was 8.8. And then after introducing the protocol, they brought it down significantly. So by reducing variation and standardizing what you can control, you can study each step in a multi-step process and how it might affect infection. So you can establish best practice, standardize things, and then move forward from there and study compliance with that protocol. So you followed all the steps, or you didn't follow certain steps, and how that they may impact the outcome, which in this case was shunt infection, and in our case is Baclofen pump infection. So quality improvement protocols identify important parts of the process, like using antibiotic wipes before the patient comes to the operating room, giving antibiotics before the surgical incision, prepping with preparing the surgical site and cleaning the skin in a certain way. We use antibiotic powder and other antibiotics. And so we've identified key steps in the surgical process, supported by evidence from shunt surgery and other surgeries, and through best practice and consensus, created a protocol that reduces variation in what we think are the critical steps and establishes a baseline, makes it routine, and then we record variation, so steps that were missed in a certain surgery, and then we can improve outcome by reducing variation and then studying if people missed certain steps and the infection rate went up, the importance of a given step in our protocol on the infection rate or the outcome. So this is kind of complicated, but this is our current surgical protocol. So you can go through it and just, these are surgical things, but pre-op CHG is just a wipe for the skin. That's an important step. Antibiotics that are given within an hour of incision, and then the type of antibiotics. We record this, but certain patients have allergies to certain ones and we might use another. And then how do we sort of prepare the surgical site once the patient was asleep in the operating room and positioned? And then ChloraPrep is an alcohol-based prep, which has been shown to be the best in terms of keeping infections low. So did we use that or something else? Ioban is an iodine impregnated barrier, sticky barrier we put on. So we use that. And then there are different ways to wash your hands or scrub, and one's a water-based scrub that you kind of probably think of with surgery. There's some waterless ones that you can kind of wipe like Purell, but a lot stronger that people use. And so we want to use a water-based scrub because in the shunt protocol with the HCRN, that showed to be very important. We double glove. We use a minimum of 1 liter of antibiotic irrigation. We have to prepare the pump before we put it in. So fill it with medicine. It comes filled with just salt water or saline. We have to get that out. And then, so it's on the sort of back table, on a sterile table, but just sitting there in the operating room. So we actually put it in a soak or a wrap of antibiotics. We give antibiotics into the spinal fluid, typically through the pump. We use antibiotic sutures. We put antibiotic powder. And then we give antibiotics after surgery. And then we have this other area just to help improve our protocol over time. So is there something people are doing that's part of their protocol, and we can study their infection rate? And if they're doing something additionally that they think is important and they have a lower infection rate, one of the sites in our group, then we might adopt that in the next iteration or next version of this protocol and slowly try to move the ball forward. This is just an example of quality improvement. So if we define the mean here, this white line in the middle, as quality of this bell curve, and this is really low infection rate, and this is maybe what we would accept as good, and then this is bad, in this example, high infection rate. The initial goal is to get rid of the worst outcomes and move the ball to the left, right? And so then we've amputated that chart, so we're avoiding the worst outcomes. And then if we go from there, we then can decrease the variation, so make it a tighter curve. So there's still variation in outcome, there's still infection, but we're much more centered around quality. So we don't have maybe these outliers in terms of really good or really bad, but over time we then move it to the left. And our definition of what's good, acceptable infection rate, for example, gets more and more strict over time. And then this is just the final kind of slide I have, but this is called the Pdsa cycle. So plan, do, study, act. And an important part of quality improvement is studying our process over time, doing it, and then trying to figure out what's important, and then making it better, and then just repeating this. So plan is describe our objective or our goal, in this case, decrease the baclofen pump infection rate, and then identify the protocol and what we think is best evidence and best practice, and then do it, run it, collect data about variance and compliance with every step of the protocol, and then the outcome, and study it and analyze it, and then improve it, and then start again. So that's quality improvement science in a nutshell. And so that's sort of all I have, but I really appreciate everybody's time today and the opportunity to talk. And I just wanted to leave a little bit of time at the end for questions that I'm certainly happy to take. So I'll stop sharing my screen and you can.
Great. Well, thank you so much, Dr. Bollo. I greatly appreciate it. First question up is from Ryan, who is quite active, considers his CP mild, and he's wondering, he does a lot of adventure sports like mountain biking.
Cool.
And he's wondering whether or not both interventions, both SDR and ITB pumps would be, actually, I'm sorry, was wondering whether or not a fall in mountain biking might disrupt a pump.
So it's a good question. I think that I would just sort of take away the acute period of time around surgery, right? So probably like once the pump is once the incisions are healed and everything is okay. I have never seen a traumatic injury like falling on a mountain bike or anything like that cause a pump to stop working. And I don't know anybody else that has. I get this question for a lot of devices like used for epilepsy and stuff like that. I've taken out pumps that have been dented and things like that that still work well. But I think the idea here is that we don't limit your life. So if you were on a mountain bike and that's important activity for you, you should do it. And if you fall and then at some point you think your spasticity is getting worse, then we should evaluate the function of the pump. But I would approach it that way rather than living in a bubble or limiting your activity. We should all be as active as we can possibly be. And I think mountain biking is a great activity. So that's how I would approach that.
Great, thank you. The next question was, does ITB affect digestive and other internal muscles?
It's not known. There's a little bit of poor quality evidence that it can improve urinary function, but I don't think it has an impact on digestion. It's a great question because a lot of patients with CP or spasticity have gastroparesis, right? Like the injury or what led to the cerebral palsy can also impact, the sort of smooth muscles of the GI system and the bladder and the internal organs as well. And so I don't think we see an impact on that in any important way. And I'm not aware of any literature that suggests that it does. I think if you take baclofen by mouth or by G-tube, you can see a lot more of those side effects.
Okay. And I'm going to keep asking the questions I see in the chat, but anybody who wants to unmute or raise their hand, I'm glad to call on them if they'd like to speak their questions. The next question was, can you explain the difference between, I'm going to pronounce it wrong, probably Lyersol and looks like cross between gabapentin and baclofen. Gabclofen, and why Gabclofen, if I'm pronouncing it right, is being used more and more.
I think that those are the trade names for baclofen. Baclofen's a generic name. And I think that I hope I'm answering this question the way you're asking it, but I would say that we in Utah serve a geographically dispersed population, and some of our patients who live in certain parts get the medicine, the physicians who refill the pumps, they get it at compounding pharmacies and they get sort of odd dosing. And the Gablofen is the Medtronic sort of brand name.
Okay.
And so and they vary in terms of concentration, and so they have different names for different concentration. It's all baclofen. We tend to recommend people kind of avoid compounding pharmacies or odd dosing because it can be hard if you travel or if we're having to figure out what's going on at a different hospital. But I think those are just different brand names, and I think that Medtronic is a company that makes most of the pumps we use, all of the pumps I use, and I think there's one other brand on the market, but I think they also they make the medication. And I may be wrong about this, but I think that Gablofen is the higher concentration. I think that that's helpful because it leads to a longer period of time in between refills.
Great. Is there a difference in the infection rate related to the age of the patient? My son is 27 and we're planning to get a pump for the first time.
Yeah, I think that we think it probably is the published infection rate in adults is lower than it is in children. It's still a major problem, but it's a bigger problem in the pediatric literature than it is in the adult literature. So it's less of a problem in adults.
Okay. So Poonam says far and away, well, by far the best explanation that I have heard. Thank you. So kudos to you. And for an adult with crouch gait and contractures, would ITB or SDR impact mobility?
It may. So I would just say, and I should have said this during the talk, but I think that either procedure, the best practice is a multidisciplinary team. And there are different things that different places do, but I think trying to get like a gait study where you can get objective measures of strength, tone, and range of motion is very, very helpful, especially like at an experienced center that's used to applying these therapies or these treatments, baclofen pumps and rhizotomies in patients after evaluating gait studies and then seeing a gait study after the treatment. But it certainly can. And the other thing that we do and that some other centers do is the Baclofen Trial, right? You could give a Baclofen Trial and sort of take away the tone and see what the strength is in isolation. And that's the technique a lot of centers use to try to determine if treating the tone will impact the mobility in a way that you didn't want.
Great answer, thanks. Can a patient have a pump and then get a rhizotomy?
Yes. So we've had several patients. You have to titrate the pump dose down to saline for the rhizotomy to work, because we do neuromonitoring, or we do under the microscope, we have little probes and we monitor nerves during surgery. And if baclofen is in the spinal fluid, we don't get good responses. So it has to be titrated down to saline for at least 5 days before the rhizotomy. And then we will typically take it out, the pump out, and then do the rhizotomy all in the same, under the same anesthetic at the same time. But you can, it's actually a lot harder to go the other way. So the rhizotomy causes a lot of scar tissue, and it can be hard to put the catheter where you want it after a rhizotomy. So I think if you're considering both or one and then the other, I think that the thing to consider is maybe the pump first.
And I think what's the last question we have served up before I ask if there are any additional ones is, can a new pump be placed after an infection has been treated and resolved?
Yes. Some people put it on the other side. I don't do that because there's no evidence and it's a fairly large incision. But yes, you can put a new pump in after an infection's been treated. There are people that that experience is overwhelming and difficult, and people who've gone through infections often aren't interested in another pump, but it's certainly safe. And as long as the infection's been treated and eradicated, you should be at the standard baseline risk for a new pump surgery.
So, Dr. Bollo, there are 2 more questions if you feel like you have time. I mean, you've been very generous with your time. I want to just be cautious of that.
Oh yeah, I'm happy to keep going.
Okay. Amber, I'm going to come back to you in a second.
Sure.
How do you decide the level to place the catheter in the spine? I'm concerned about affecting trunk control, but would like at least a little effect on arms as well as legs.
I think that's a great question. So these are tricky, right? Because I mean, I placed a pump on Tuesday and we had a discussion with this family, and I think it comes down to your goals and the goals of the family and the patient. And so there are trade-offs to be made, because if you put the tip of the catheter to control the arms, you get less impact on the legs, and you may not get the control you want in the legs. If you put it up high, you may affect all of the muscles that control trunk tone. And so that may be harmful, or it may lead to, effects that you don't want, or you may not be able to titrate it up to the dose that would give you the impact you wanted in the legs. So I would also say there are patients who have a lot of spasticity or tightness in one arm and not the other, and have functional use of that arm, be it as a helper hand or even finger control. And if you were to put the tip of the catheter high, that could also limit the dose, right? Because you can't treat the left arm different than the right. And if the right arm's highly functional and the left arm's very tight, you will be limited in terms of the amount of tightness you can resolve or spasticity you can resolve in one side, because you're going to impact function on the other. So I think these are trade-offs, and I think they require just a, joint decision-making between the family and the patient and the provider about what the right trade-offs are. So if somebody has, great trunk control and really bad spasticity in the lower extremities, I think that, we generally will put it at the lower end of the chest, the tip of the catheter. But I think that those are all really important questions. And I think it just requires a sort of case-by-case discussion and this shared decision-making model between the provider, the spasticity team, and the family. But I think you kind of have to agree upon it. And I wouldn't, I generally don't practice in a situation where I'm telling you where it needs to go. I think we have to talk about it.
Great, thanks. Amber, go ahead.
Yeah, I was wondering, what do you see functionally over time as a therapist treating primarily pediatrics? I've seen very varying degrees of how the baclofen pump has affected spasticity. So I'm just interested from a functional standpoint. And then the other question that I wanted to piggyback on that was, I have spastic diplegia myself, and I was told 25 years ago by a neurologist that Medtronic was going to make the pump small enough to go behind your ear at one point, because cosmesis was very important to me at that time. So I didn't want a big pump in my abdomen because I'm pretty petite. So I'm just wondering, where are they in that process also?
I mean, I think that what limits the size of the pump is the size of the reservoir for medication. And so the concentration of medication, like, so 3,000 mics per mil was this sort of Baclofen study. I think the current highest dose that people use is 2,000 micrograms per ml. So and the trade-offs are about how often you want to come in and have it refilled. So I think that I can't speak for Medtronic, but if I were, planning devices there, I think it's unlikely they're going to make a device that small. Okay. I think the reason is because they wouldn't implant very many of them because it would have a very small reservoir. And I think as the concentration of the medication goes up, it tends to precipitate out of solution, or just kind of like salt water. If you have too much salt, then the salt comes out the bottom, and then it won't be infused, or it affects the infusion through the catheter. So I think that there are just some physical limitations to those things, and I think it's probably why they haven't done it. So I think that they've actually they used to have an 18 milliliter pump, and they've gone to 20 and 40. I think it's unlikely they're going to make one smaller than that. And those, as you probably know, are the same sort of round diameters, just one's thicker than the other. Yeah. So I think it's unlikely that you're going to see something like that.
And
that's just my opinion. Yeah.
Okay.
And I think the functional variability has a lot to do with how the pump is managed. So like the dose that people are comfortable going up to, and if generally you want to titrate it to effect and impact. But I think that if the catheter, like we were talking about earlier, is placed in a certain way that limits the dose, you're not going to see the same sort of benefit. And so maybe moving the catheter, but that's a surgery and risks infection, so people may not want to do that. There are certainly providers that have different philosophies about how aggressive to be with titrating the pumps up and down, and I think that that's what you see. I think that I think these devices tend to be very finicky, and I think the bottom line in terms of revising pumps and catheters, because they can block and break, is how the patient is doing. But we see some patients, so take a GMFCS5 patient, for example, who might have scoliosis, right? And they have a pump and they had a good effect initially, and then sometimes they'll go through spine surgery, which is a really big operation to straighten their spine, right? And then they don't see a benefit much anymore, and then we find out the catheter was cut, or there was some issue that was unresolved. So we try our best to sort of evaluate the pumps and make sure they're working regularly. But some patients, you titrate the medicine up high and you don't see an improvement, that should be a red flag that maybe there's a malfunction and the medicine's not going where it needs to go. And then others, it's just maybe a treatment philosophy between different providers about what dose they'll tolerate in terms of how high to go. But you see patients on a range from anywhere between like 100 micrograms per day of a continuous infusion at the low end to sometimes up to 1,200. So.
Thank you.
Great. I think the last question for the evening is from Caitlin Bunner. Caitlin, do you want to ask your question?
Yeah.
Oh, having a little trouble hearing you, Caitlin. Try again.
Sorry.
That's okay.
Is DPS being used for Dystonia CP, or I read that it's not very effective in CP patients. Is that true?
That's a really great question. So we utilize DBS for patients with dystonia, and it works very, very well in the setting of what we call primary dystonia, where it's a specific gene mutation leading to it, and we wouldn't group those patients into the CP category. Patients with CP tend to have what we call a secondary dystonia. So it's not because of a gene mutation that caused the dystonia that they were born with, but because of an injury like we're talking about. And in that situation, secondary dystonia, DBS is less effective. It doesn't mean that it's not effective, but it has it work, and I just want to be careful about the way we talk about this so we're all on the same page. So I don't think it doesn't work as well, like it works, but not just a little bit. I think it just is effective in a smaller group of patients. So when I think about DBS for secondary dystonia in CP, about a quarter of patients have a meaningful response. And there's some work going on trying to identify who those patients are with like an MRI scan of their brain or other imaging up front. But as it stands today, it's very challenging. So I would see DBS for dystonia and CP as a last resort and certainly an option on the table. Some people with CP have very severe dystonia and they have spasticity and it's a mixed picture, but dystonia predominates. And Baclofen works in about 50% of those patients and usually requires a much higher dose of intrathecal Baclofen, so a pump. So I would try that first. But DBS may be effective, and the two might work together well if you're not getting where you need to with Baclofen. There are other even more aggressive options for dystonia that work well, but people don't do a lot of, which is like a ventral rhizotomy, so actually cutting the motor roots, because that will certainly decrease the dystonia, but the side effect is weakness. So it depends on the type of dystonia, how effective DBS is. And I would say in CP, we usually see secondary dystonia. Baclofen works better, but requires a higher dose. But DBS should certainly be a treatment option for patients who aren't responding and have severe dystonia.
And let me clarify, someone asked, so DBS is deep brain stimulation, probes are put deeply into the brain. Rob, can you just say a little bit about that, just so that people understand what that is?
We put them in the thalamus, which are sort of deep areas in the brain. So the most common use of deep brain stimulation is Parkinson's disease in adults, and then essential tremor. Those it's like very highly effective for. Those are, you may see videos where patients are in the operating room and they turn it on. They do often those surgeries awake, and they record as they pass the probe, and you can see an immediate benefit, and it's really remarkable. You can see patients like playing an instrument that weren't able to and now can as soon as you turn it on in the operating room while they're having this awake surgery. So deep brain stimulation, by far the biggest uses of it are Parkinson's disease and essential tremor, and it's very effective in those situations. And then its use for dystonia is usually for this called primary dystonia. So there are a couple of known gene mutations that lead to dystonia without a lot of other symptoms, and it's very effective for those. And then CP is this secondary sort of mixed picture dystonia, which it's less effective for, but certainly should be available for patients that don't respond to other treatments. But yeah, so it requires us to put these stimulating electrodes deep into the brain, and then they're tunneled down. We make an incision behind the ear, and then they're tunneled down to the stimulator sits in a pocket, usually underneath the clavicle. It can be on one side or both sides, depending on the specific brand you're using and things like that. But it can be quite effective. We also do it for epilepsy.
Well, Dr. Bollo, I have to thank you, and you just an amazing job taking very technical things right down to the drawing that you do and making them simplified. But no, it was really a great explanation of the GMFCS and the sort of progression of intervention, and in particular the role of the pump. So thank you very much for your generous time this evening. Thanks all of you for attending. And feel free to ask questions on the MyCP forum, and we'll get them answered if you have more questions there. Thanks all.
Thanks for your attention. It was my pleasure and my privilege. Thanks, Paul.
Yeah, you're welcome. Thanks, Rob.